Well, welcome back. We're back with another pathology review video. Just the basics here, guys. We talked about the routes of entry and dissemination of microbes, and in previous videos we talked about cancer and neoplasia. So we know how microbes enter the body, right? And we know that sometimes viruses and certain bacterial toxins may also travel through nerves. Well, let's talk about prions. Prions can cause a lot of trouble. We're talking about misfolded proteins. We can also talk about cystic fibrosis, bovine spongiform encephalitis. Anyway, prions. They result from an abnormal accumulation causing neuron damage, causing spongiform encephalopathies, CJD or Creutzfeldt-Jakob disease. Remember that prions are composed of abnormal forms of the host protein. So what is another form of protein folding disease? How about cystic fibrosis? So in previous videos we talked about cystic fibrosis in detail, particularly molecular biology, and we know this is a mutation of a CFTR, transmembrane conductance regulator gene. So with this difficulty, it's not possible to transport chloride. So just to summarize here, we should know that CFTR is an ABC transporter class ion channel that conducts chloride and thiocyanate ions across the epithelial cell membranes, and the mutations of the CFTR gene affect chloride ion channel function, which then leads to the dysregulation of epithelial fluid transport in the lung. We know this. The lung and the pancreas and other organs, and this results in cystic fibrosis. Thank you, Wikipedia. So we should remember this figure and the process leading to cystic fibrosis. Remember that it is a problem with the chloride channels and the transport of chloride, and a problem with the CFTR mutation of this gene. Anyway, we're not going to discuss any of the clinical manifestations. We're just talking mostly about the biochemistry here and basic pathology. Let's move on and talk a little bit more. Let's talk about pancreatic insufficiency. So remember that pancreatic insufficiency is a result of cystic fibrosis. Just reading here. It is the inability to properly digest food due to a lack of digestive enzymes made in the pancreas, and EPI is found in humans affected with cystic fibrosis and Schwartzman-Diamond syndrome, and is also common in dogs. Anyway, so remember here that the ducts are dilated and plugged with eosinophilic mucin, and the parenchymal glands are atrophic and replaced by fibrous tissue. This is typically associated with the issues of bicarbonate transport. Anyway, this is a result of cystic fibrosis. Remember the difficulties with chloride transport and the CFTR gene mutation. Looking at some slides here, but you can't see. I'm just going to repeat this because I think it may be important. We have to understand what is endothelial dysfunction. You can't see the slide here, but basically it says the endothelial dysfunction is defined as an altered phenotype that impairs vasoreactivity and induces a surface that is thrombogenic or abnormally adhesive to inflammatory cells. It is responsible, at least in part, for the initiation of thrombus formation, atherosclerosis, and the vascular lesions of hypertension and other disorders. So let's move on and talk a little bit more. Okay, well, moving along, so we're just going to have a quick review here. We're talking about blood pressure regulation, which you've talked about so many times in so many different classes, in particular in pharmacology, where we discussed the RAS system. but we're not going to go in detail again here. Just some basic points we should remember about renin, angiotensin, aldosterone, for example. Remember that if the perfusion of the juxtaglomerular apparatus in the kidney decreases, then the juxtaglomerular cells release what? Renin. And renin cleaves an inactive peptide called what? Angiotensinogen. And then renin converts this angiotensinogen to what? Angiotensin 1. And angiotensin 1 is then converted to what? Angiotensin 2 by angiotensin converting enzyme, which is ACE. We talked about the ACE inhibitors, which is found mainly in where? In lung capillaries. Again, angiotensin 1 is then converted to angiotensin 2 by angiotensin converting enzyme, ACE, which is found mainly in lung capillaries. And angiotensin 2 is the major bioactive product in the renin-angiotensin system. Remember that angiotensin 2 acts as an endocrine, autocrine, paracrine, and intracrine hormone. We're not going to talk too much about that. Well, I guess we are going to talk a little bit more about it because I like the way Wikipedia says it. So when you think about renin, we can say that its primary function is therefore to eventually cause an increase in blood pressure, leading to restoration of perfusion pressure in the kidney. So how does it do that? As we just said, it activates the renin-angiotensin system by cleaving angiotensinogen produced by the liver to yield angiotensin 1, which is further converted to angiotensin 2 by ACE. And the angiotensin converting enzyme primarily within the capillaries of the lungs. Angiotensin 2 then constricts blood vessels, increases the secretion of ADH and aldosterone, and stimulates the hypothalamus to activate the thirst reflex, each leading to an increase in blood pressure. So there you have it, how renin causes an increase in blood pressure. So what is a simple definition for angiotensin then? It is a peptide hormone that causes vasoconstriction and subsequent increase in blood pressure. And what does angiotensin stimulate the release of? Aldosterone. And what does aldosterone do? It promotes sodium retention in the distal nephron in the kidney, which also drives blood pressure up. So I like talking about this many ways. I'm just reading Wikipedia here. I'm going to ask the question, what is ACE? What is angiotensin converting enzyme? What does it do? It indirectly increases blood pressure by causing blood vessels to constrict. It does that by converting angiotensin 1 to angiotensin 2, which constricts the vessels. For this reason, drugs known as ACE inhibitors are used to lower blood pressure. So it seems like I've studied this many times, but I always find that before I take a test, even though I've gone over the lectures and gone over the books and talked it out, it's always good to go to Google and look for MCQs on that subject, because that is really the way to test your knowledge, and there's only so many ways you can ask about the RAS system. Maybe 20 or 30 questions for the basic system. So if you do that, you're probably going to do well on the quiz. Famous last words. Okay, well, so regarding blood pressure, we know, of course, that basically diastolic pressure of 90 and systolic pressure of 140, anything changed there is cause for concern, but we need to remember what is hyaline arteriosclerosis. Arteriosclerosis, say it right. So you're not looking at the picture here, I'm looking at vascular pathology in hypertension. And I can see that the arteriolar wall is thickened with increased protein deposition. We call this hyalinized. and the lumen is markedly narrowed. And this is associated with aging, hypertension, and diabetes. So we can also discuss hyperplastic arteriosclerosis. We have hyaline arteriosclerosis and hyperplastic arteriosclerosis. In this case, this occurs in severe hypertension. You would see onion skin lesions, smooth muscle cells with thickened, reduplicated basement membranes, vessel wall necrosis, particularly in the kidney. So that is hyperplastic arteriosclerosis. And what was the other one? Hyaline arteriosclerosis. We're talking about hypertension here again. Now we talked about hypertension in detail in other courses, particularly in pharmacology. And of course in the system-based we'll talk about in much more detail. But here, let's talk about what is essential primary hypertension. This is concerning 95% of the cases. It's benign, asymptomatic. It's the silent disease. We're talking here about hyaline arteriosclerosis, not hyperplastic. So bullet points here: late manifestations, late ventricular hypertrophy, congestive heart failure, accelerated atherosclerosis, myocardial infarction, aneurysm, intracerebral hemorrhage, renal failure. And how about malignant or accelerated hypertension? 5%. In this case, diastolic pressure is greater than 120, and you have end organ damage. Micro hyperplastic arteriosclerosis, fibrinoid necrosis of the vessel wall. So you can see with this hyperplastic arteriosclerosis, this is much more serious. You have the onion skin lesions, vessel wall necrosis. Okay, so what is the generic term for anything which hardens arteries? Arteriosclerosis. Atherosclerosis 99%, and Monckeberg medial calcific sclerosis is 1%. What is arteriosclerosis? This involves the small arteries and arterioles, generally regarded as not strictly being part of atherosclerosis, but more related to hypertension and or diabetes. So regarding atherosclerosis, definition: clearly, lipid deposition and intimal thickening of large and medium-sized arteries, resulting in fatty streaks and atheromatous plaques. So this is characterized by intimal lesions called atheromas. And looking at the picture here, we can see a fibrous cap, smooth muscle cells, macrophages, foam cells, lymphocytes, collagen, elastin, proteoglycans, and neovascularization. And we have a necrotic center, cell debris, cholesterol crystals, foam cells, and calcium. And then outside we have the media. So remember the atheromas in atherosclerosis, foam cells, lipid deposition. So briefly list or explain the pathogenesis of atherosclerosis. 1. Endothelial injury. 2. Adhesion of monocytes and platelets. 3. Migration of monocytes and smooth muscle cells into the intima. 3. Smooth muscle cell proliferation into the intima with ECM production. And 5. A well-developed plaque. Very easy to remember. And what are some of the clinical complications of atherosclerosis? Ischemic heart disease, cerebrovascular accidents, atheremboli, aneurysm formation, peripheral vascular disease, and mesenteric artery occlusion. What are some of the risk factors? So name some of the risk factors for atherosclerosis. Hyperlipidemia, hypertension, smoking, diabetes, male obesity, sedentary lifestyle, stress, old age, familial genetic factors. Hyperlipidemia, hypertension, smoking, diabetes, male obesity, sedentary lifestyle, stress, old age, familial genetic factors. Got that? So then how can we describe the natural history and morphologic features of some of the main pathogenic events, clinical complications in atherosclerosis? So we have the preclinical stage and the clinical stage. In the preclinical stage, we have a normal artery, then there is a fatty streak, which leads to fibrofatty plaque, then to advanced vulnerable plaque. In the clinical phase, usually middle-aged to elderly people, we have aneurysm and rupture, occlusion by thrombus, and then a critical stenosis. I'm skipping some of the explanations of the steps here, but that's basically how it goes. Well, it seems like this is endless, and it is. We have 80 slides to get through. We're going to talk about aneurysms, so make sure you know about these aneurysms. We've talked about this before quite in detail in histology, and here basically we should know true versus false, atherosclerotic, non-atherosclerotic, congenital, lytic, traumatic, mycotic, secondary to vasculitis, saccular, i.e. berry. We talked about berry aneurysms before, fusiform, and a dissection versus a non-dissection. So first, the very basic form of an aneurysm is called a true aneurysm, and it is what type? It is a saccular type, and in this case the wall focally bulges outward and may be attenuated, but is otherwise intact. So that is a true or saccular aneurysm. So here's a question here. Where do most abdominal aortic aneurysms occur? They occur between the renal arteries and the bifurcation of the aorta. So what is a false aneurysm? Can you picture that? In this case, the wall is ruptured and there is a collection of blood or hematoma that is bounded externally by adherent extravascular tissues. So we have extravascular connective tissue, extravasion of blood, and a hematoma. This is a false aneurysm. Remember that a real or a true aneurysm is saccular type and the wall focally bulges outward. But in this case, we're having a hematoma, an extravascular connective tissue, an extravasation of blood. And thirdly, let's talk about a dissection. What is a dissection? Dissection, in this case, blood has entered the wall of the vessel and separated the layers. So just to give a little bit more detail, the blood penetrates the intima and enters the media layer, in case you're asked that question. And what are the three layers of the aorta? They are the intima, the media, and the adventitia. The intima is in direct contact with the blood inside the vessel and mainly consists of the layer of endothelial cells on the basement membrane, and the media contains the connective muscle tissue, and the vessel is protected on the outside by the adventitia, comprising connective tissue, which we discussed in detail in our histology class, and I can't believe that I forgot it. So here we go. Remember those